Ladies and gentlemen, colleagues, friends, welcome to this Health Forum. So may I ask the speakers to come here up front? Hier, können wir dann gleich hier. Okay, my name is Harald Renz. I'm from Marburg, Germany. In the previous session, we had the Marburg virus, and the Marburg virus was discovered 50 years ago at our university in Germany because of an outbreak happening at one of the companies producing vaccines, actually. But today we are not focusing on infectious diseases. We are focusing on the non-communicable diseases. And just this morning, I think we heard a lot about the importance of the double burden, which is now really heavily impacting Sub-Saharan Africa. On the one hand side, the burden of infectious disease. On the other side, the burden of non-communicable diseases. And of course, between both entities, infectious and non-infectious, there are lots and lots of relationships, meaning that infections cause development of non-communicable diseases like some cancers, autoimmunities. Infectious diseases cause exacerbation of non-communicable disease. And on the other side, people suffering from NCDs are more prone for infections. We have seen that with the corona pandemic. So this symposium here today is sponsored by the GIZ, the German organization for funding under the umbrella of the German Federal Ministry of Economic Development. GIZ is one of the major funders, also in Tanzania and of course also beyond for many, many activities, smaller and larger activities. And one of the activities is the Hospital Partnership Program. And actually, the GIZ is running more than 20 hospital partnership activities here currently in Tanzania. And you can imagine it was very, very hard and difficult to select only a few of them to present today, to give you an idea, an overview, what is going on in the field of non-communicable diseases. And we will cover several non-communicable diseases in this symposium. And I would like to introduce to you briefly the speakers today. Let me start with Dr. Ubuguyu. Dr. Ubuguyu is substituting for Professor Pascal Rugaggio, who is unfortunately not able to come today. Dr. Ubuguyu is the head of the Non-Communicable Disease Program in the Ministry of Health. Dr. Ubuguyu, may I ask you to come to the stage? I think maybe to take here the first seat over there. I don't know where you. Yeah. Thank you. Next, I would like to ask Dr. George Masengi to come to the stage. He will, together with Dr. Mary from NIMRI, discuss the epidemiology of non-communicable disease. Then it's a great pleasure to welcome Dr. Oliver Henke from Germany and also from the northern zone in Tanzania. He is one of the leading experts in cancer screening. Welcome to you. And I would like to welcome also Dr. Frieda. Where's Dr. Frieda? Behind the column. Please come up here to the stage. She is representing the field of emergency medicine at KCMC, Kilimanjaro Christian Medical Center, at the emergency department. She will talk about the implementation of a master program in emergency medicine. And we also have activities for bachelor students in medicine, for NCDs. And I like to welcome Dr. Christian Kreisel to come to the stage, who is responsible for these programs as well. And finally, we have Professor Irene Kivelo from KCRI. She will introduce to you a very big project, the Center of Excellence in Laboratory Medicine. So we have really, you may welcome all of them with an applause, maybe. So that's really, yeah, welcome. Okay, so for the sake of the time, may I ask Dr. Ubuguyu to give his keynote lecture. Yes. Do you want to start with from current challenge to solutions, how to tackle the NCD pandemic in Tanzania? Well, who is, I mean, we are very flexible with the order also. You want to take this one? Oh, the presentation. Mm-hmm. You want to come here to the podium or? Mm-hmm. You want to sit there? Okay.
Okay, good morning, everyone. As I've been introduced, my name is Omari Buguyu. I'm doctor by professional, I'm psychiatrist, and I've experienced for almost 12 years as a clinician and almost 6 years as an administrator at Ministry of Health. And actually, I've been climbing the radar as a coordinator of mental health, then program manager, and director of curative services, and then now I'm assistant director for non-communicable diseases. So I have a background on clinical aspects, administrative aspect at almost all levels of administrations. And during the past 20 years, as an expert within the health field, we have observed significant change on disease pattern. Initially, when we were in the medical schools, we were told that, at least among ourselves, that NCD is a disease of the West. And actually, when we go for clinical rotation, almost 80 to 90% of our patients were those who had an infectious condition. There was a wing dedicated for TB, there's a wing dedicated for HIV, and there's a lot of people with malnutrition, and on and off people with either diabetes or cardiac conditions, but most of them were on the severe form of the diseases. So the change on transition of the disease, it is quite evident when you visit hospital, either at OPD or inpatient care. At the moment, we found majority, 80 to 90% of our patients now has either hypertension, diabetes, or those who have stroke, and we have a lot of people with cancer as well. If you look at the burden of non-communicable disease in the country, it is very unfortunate that Dr. Mary Maige is not here, and Professor Kaushik as well, they are not here, and Professor Swai. In 1980s, when we conduct our baseline survey, especially population-based data in Tanzania, especially Dar es Salaam and Kilimanjaro back then, what we found out that it was only 1% of Tanzanians who had diabetes and 5% who had hypertension. When we did step survey in 2012, what we found out that for diabetes, we have 9.1% and 26% for hypertension. So for these two major conditions, we have witnessed at least 5 to 8-fold increase on non-communicable diseases in these two conditions. Our current status for cancer patients, we have almost 40,500 new cases each year, and unfortunately, we lose almost 26,000 people for cancer almost every year. And it is very unfortunate, again, majority are female, women with cancer of cervix and cancer of breasts. These are two leading cause of cancer and cancer mortality. With the general cancer prevalence, we found out that 1/3 of all cancer cases is from these two conditions, and more than half of mortality or death resulted from cancer also attributed by these two conditions. So it is pretty and one of the serious issues. If you look at a condition like sickle cell, which is not very prominent in our societies, we may find out that, one, we have almost 0.5 to 1% of our population, of our newborn, found out to have sickle cell. With all other problems that we have in this country, we might say that 0.5% is not of public health importance. But unfortunately, 70 to 90% of these children born with sickle cell, they don't reach their 5th birthday. So looking into that perspective, it is quite significant. We were looking at burden of non-communicable diseases in individual. There are people who conducted the studies, number of sessions done in our country, and what we found out, the economic burden to the household increased significantly for more than 6 times when you have non-communicable diseases as compared to the families with patients with communicable diseases. And with our NHIF, almost 20% of all reimbursement goes to just 2 conditions, dialysis and cancer care. So you can imagine how much we need to support our healthcare financing when it comes to non-communicable diseases. I was doing some analysis of our DHS2 data, just looking for the distribution pattern of our NCDs in the country, and that was data for 2021 and 2022, and looking which regions has the highest burden of non-communicable diseases. And we found out that Dar es Salaam, Kilimanjaro, and Arusha have high number of cases per 1,000 population. And it was surprising to most of us that Lake region has the lowest prevalence in terms of total number of cases per 1,000 population, and region like Iringa, Mbeya, and Njombe, where there is challenge of undernutrition, stunting, and the other forms of malnutrition in children, also comes high among few regions with a top 10 condition for non-communicable diseases. So it is quite rampant, and almost entire country has been touched. So all of these data to us, it's just part of gives us highlights where there's a problems, gives us reasons to intervene. Dr. Mary will witness when we did STEP survey in 2012, and in most of our campaigns when we were looking for the non-communicable diseases, forget about the numbers, the prevalence that we have. The most alarming issue is almost 70 to 80% of people who are diagnosed or found to have risk factor during campaign, they are never aware of their condition. So many people are living with the NCDs, but they don't know. It is tradition, and it is very unfortunate to most of us. We go to the hospital once we have symptoms. And this is unfortunate in non-communicable diseases, because once you have the symptoms, it means that you have advanced condition. People with cancer, if you see you have a mass and it is not painful, doesn't bleed, doesn't change color. No one bothers. Just say, I'm disfigured, you live with it until when you see first symptoms. And this makes us almost 80% of people who are attending Ocean Road today, they are on the third or fourth stage of cancer. So become very difficult to intervene. So as a country, 2 years ago, we reviewed our national NCD strategic plan, and we had 4 major strategic objectives and strategic areas that we see these are very important to us. One was on leadership and coordination. We know there is a meager resources for non-communicable disease, but unfortunately, the little that we have, we are not utilizing it fully. When Ocean Road is procuring medication for cancer, Buganda also is procuring using different mechanisms. So we found out that we don't have proper coordination, especially pooling of resources and things of that nature. So leadership and coordination come out that this is very important, and we all know that when you look at social determinant of health, NCD doesn't fall under health department alone. There's multiple key stakeholders who are involved in NCD care, so we were looking for national multi-sectoral coordination for non-communicable disease, and we have 3 levels of coordination. One at a national level where we highlighted that Prime Minister's offices is the one who is coordinating at a national level, and at sub-national level, President Office, Regional Administration and Local Government, TAMISEMI, is the one who is coordinating on that area, and the technical coordination is under Ministry of Health. So these 3 layers of coordination is very important for us, and becomes one of the key strategic area. And the second area as a key strategic area is on strengthening healthcare system on its own, whereby we were looking at strengthening human resource for health. We know that we have very little resources, less than 40% of a human resource for health. Then we have to mitigate in that area, and where should we invest more? We found out that there is a million reasons of investing at PHC, and over the past 1 year, we invested massively on our public health centers. We trained almost all public health facilities at health centers level, and we have 2 clinicians and 2 nurses, thinking that we can invest at that area. And with that, we are thinking of a triage for all people who are coming for services in health centers. And the reason is people seek health services with their malaria, going to the hospital because they have high fever, and we missed their blood pressure, we missed their high blood glucose, because we don't offer routine checkup on those areas. So our investment at PHC is also go concurrently with investment on our triage unit. Then promotion activities is our number 1 priority, because with promotion services, it is very cost effective. 75 to 80% is massive. If at that level people are not aware of their condition and they don't find the reason to check for their health status, we see we need to invest on awareness so that they can engage on the meaningful healthcare, meaningful checking of their health. And then HMIS, especially MTUA, and establishing a specific registry for NCD, we think that might give us a good outcome, because if we have the registry, it will be very easy for us to make a follow-up with the disease of interest. And hypertension, diabetes, stroke, cancer, mental health, if we have a registry of at least 7 major conditions, it will be very easy to understand the disease pattern and intervene. And last, we are having campaigns at the workplace. With HIV, we know we have key and vulnerable population. We have seen in this country, for sure, people at work are key and vulnerable for NCDs. It is an anecdotal finding, it's not a researched one. When most of us retired on our 60th birthday, many of us don't reach our 70th years because we die within 10 years after retirement. One, we live a sedentary behavior. We are not physically active, but at least when we work, we get some chances of moving around and engage in some of physical activities. After that, our counterparts who are not working, because they are on their routines, they live longer than those who are working because of drastic changes in our health. So these people at work also, we take them as a key and vulnerable, and we have special campaigns at the workplace now, just checking what are the risks, what are the opportunities, and what are the barriers so that we can intervene. I think I've took more than what I've been allocated for, so let me leave my mic to other colleagues. Thank you very much.
Yeah, thank you very much, Dr. Ubuguyu, for this, I think, very important insight into the activities of the Ministry of Health in this regard and impressive programs. I'm sure we will have time later to discuss that all together. In the meantime, I'm also delighted to welcome Dr. Mary McGee from NIMRI. Thank you for coming, and I would like to hand over to, I don't know who will give the presentation, you or? Who wants to go first? Okay, when you go first, and because you have to go to another session in the other room. Okay, thank you.
Thank you. Can I have my presentation now? I would like to start there.
To come here?
Yeah. Good morning. Sorry, I came a little bit late. There's a confusion in the program, so I'm presenting in 2 different rooms. I'm glad that Dr. Ubuguyu started telling you all the good things that they're doing, because my job here is to tell you how bad things are. And I'm glad that he started with that, and we'll be comfortable to know that something is already being done. Can I have my slides up, please? So I'll talk about the current burden of NCDs and what we need to do for primary prevention, and what are the risk factors for the rising burden of NCDs that we're seeing in Tanzania. My name is Dr. Mary Maige. I'm the Director of Research Information and Regulatory Affairs at NIMRI. So if your ethics approvals are not on time, I am to blame. Yeah, so.
So they're having an IT issue. They've asked for links.
Oh, okay. All right, so. Okay. So just to also give a bit of background, the work that we're presenting is a synthesis of data from the Global Burden of Disease report that is of 2017, the National NCD STEP survey that is of 2012, but I'm happy also to announce that we have an ongoing country survey that is ongoing, so we should have an update in a few months. And also, the work that I'm presenting was a synthesis of the current burden of NCD, and we produced this country report in 2020. So I just want to set the stage to the data. Some of it might be alarming, but we are happy to know that things are moving. Yeah. Yeah. Yeah, maybe we can discuss what Dr. Ubugui was. Because I'm presenting data, so I can't speak on top of my head. Dr. Ubugui, would you like to?
Yeah, thank you. So apparently it will take a few moments until we have reconnected here the computers. So maybe we use the time to start a round of discussion. Are there any questions to Dr. Ubuguyu regarding the initiatives and activities of the Ministry of Health with regard to set up programs? From one of your slides, it became clear that the primary healthcare sector is really very important in terms of providing screening programs, maybe also early intervention programs. You mentioned diabetes. You also mentioned cancer screening. Where do you see the major challenges?
One, as a ministry or as a government, we see the primary health care is a game changer. This is from the literature, but from what we witnessed. When you look at healthcare pyramids, you might find out that our secondary and tertiary level of care, that is regional referral hospital and zonal facilities, they contribute to less than 100 of healthcare facilities out of 10,000 healthcare facilities in the country. So they contribute to less than 10% of what we have in the country. Actually, it is just 1% of the entire healthcare facility that we have in the countries. The base of the pyramid, dispensaries, has more than 7,000 healthcare facilities. Yes. And health centers has almost 10% of the remaining part of the care. So it is easy to invest at health centers because there are many and they are in almost all wards. In the wards, there's schools, there's dispensary within a ward, and there's a workplace. So if you invest at the health centers, you'll be able to cater for school, you'll be able to cater for workplace, you'll be able to support a dispensary where it's a primary entry of care, but you'll go to the community. So with community health care workers, our primary hub could be at health centers. The opportunities there are not many, just 700, and we are able to train them. There are not many, so it is easy to provide them with early detection measures. And there are not many because it is easy also to make sure that it is saturated with the healthcare providers. The challenges are, at the moment, our workforce for healthcare services, it is below 50%. So this is trickle down in whatever that we are doing. We are doing it at less than 50% of what is intended because this is the workforce that we have. Mm-hmm. Again, issue for awareness. Because people don't test early, they come with complications. Yeah. So primary health care level, it's not good entry when you have people coming with complication. So this has become tricky. But what we are doing at the moment, improving healthcare, awareness campaign in the community, we want to create more demand at early stage, and we know that we cater them at health center. So the challenges are two: human resources, and people comes with complications already, which doesn't fit at PHC. This goes to secondary and tertiary level of care.
Thank you. Thank you very much. There was another question here from the auditorium.
Yes, it was actually just answered, but thanks, Dr. Buguyu, for your elaborations. I'm Julius from D3, and we implement a community health worker program in Zanzibar, nationally scaled with the Ministry of Health. And I was just wondering, because you portrayed the health system pyramid, but it stopped at the dispensary level, and what kind of role community health workers can play in addressing non-communicable diseases. You've just touched upon it, but if there's anything you can elaborate on, that would be much appreciated. Or someone else from the panel.
Yeah, who wants to answer? Maybe,
of course, I cannot give any answers from the ministry, but due to my experience, I worked 6 years at KCMC in Moshi, Northern Zone. We utilized community health workers for palliative care, for example, for home-based care. And they are not only the ones doing the work right at the home, they're not reaching out to the community, they are also the multipliers of knowledge. And I think, even though we probably sometimes overstretch the community health workers by everything what they should do, but I guess they're a wonderful and really powerful resource to use to educate people in Tanzania about non-communicable diseases.
For NCDs, community health care workers alone are not enough. And we know for sure they can't do much. They can support, but that is not the end. We open our doors also to engage faith-based organization. I can tell you for sure, when we reach 60 or when you reach 70, but I'm not sure if you are Tanzanian, but in our perspective, when somebody reaches 70, even your children won't allow you to go to the street. Going to the street in Dar es Salaam, you'll never see people above 70s doing some recreation activities. When you are in Europe, you'll find many. So church and mosque, most of our elders goes to the church, not because they know that they are at the end of life, but many know that church or mosque is a safe place. If you tell your children that I'm going to the church, I'm going to the mosque, they will allow you, simply, and no one will follow you. And if you go to the mosque or church, at that age, people will give you tasks, and you socialize with other people. So recreation activities in this community we need, and we know that faith-based organization, mosques and churches play a vital role, especially on changing diseases, epidemic and interventions in general. So apart from community healthcare workers, we also engage those. Again, I was working at the methadone clinics, and people, female sex workers, they don't use traditional community healthcare workers. One, they say nothing for us without us. You have to recruit somebody who is using drugs to look for their colleagues. And initially, when we are using traditional community health care workers, when they go to the drug den, they'll never give them access. But if you are using drug user, they go into the depth of the drug den, and they allow them to come and educate them. So we know there are other key players with that. It is unfortunately, in our pyramid, it is difficult to give a clear number of how many are they, where are they. So there's no formal structure. Probably when we formalize in our pyramid, they will come very clear and you'll see them.
Thank you very much. Any further questions, comments, remarks here from the auditorium? Yes, please.
Thank you. Good morning. Yeah, I'm commenting on Dr. Obuguyu. Even churches, this problem is very serious, because I did a pilot of 100 people within a certain church of age above 40, both female and male. I found among 100 people, 56 were hypertensive. And on that 56, 13 have got a hypertensive urgency with sign of bad vision, a frequent headache, and other signs, but they are not knowing. They are not knowing that they have that problem. So this is very crucial. I think the government may forecast anything to deal with this problem and other stakeholders. Thank you.
Yeah, thank you for this comment. Thank you. So now we can continue with the program, and we continue with Dr. George Masengi, MD, PhD. You can introduce yourself and setting the course for NCDs where we need to prioritize. Looking forward.
Asante sana. Good afternoon, everyone. Kind apology for the technological inconveniences. I'm glad TANESCO did not also decide to do something. So yes, my name's George Msengi. I am a PhD student, but also I work very closely with Dr. Obuguyu. I would literally say I'm his right-hand pocket. But yes, work very closely with Professor Renz on a number of initiatives between Marburg and Tanzania, and I work with Dr. Mary Mayige very closely, and we're currently doing the STEPS survey as a follow-up to the 2012. Next slide. So I just want to set the course on NCDs and try to bring on a couple of experiences and bring to light what I think are key takes from these experiences. So these are some of the common numbers to those who do not know them, but when you look at the global burden of diseases and you look at the key issue when you talk about morbidity and mortality, NCDs are the pivotal of that. And this is from the World Economic Forum. We know that 41 million people each year die from NCDs, and furthermore 74% of all this death are from low and middle income countries. The numbers are still going up, and I think when Dr. Mary comes to present on the STEP survey, we'll realize that the trend is rising for NCDs. We have really invested a lot on the communicables, but not much on the non-communicables. Next slide. These are just some of the projections. Murray and Lopez, through the Global Burden of Disease, had done this projection in 1996, and coincidentally, it's actually following this trend. The deaths are really on a rise. Next slide. Now, when you look at, I do not have a pointer, but when you look at the leading cause of death globally, when you do a comparative between 2000 and 2019, you realize that the color shaded dot is 2019 and the blank dot is 2000. So you can see that all the color shaded dots are NCDs, and at the bottom you see numbers in millions. So you can see that the trend for almost all the NCDs is rising. In comparative, when you look at the trend, for example, of lower respiratory tract infection, it has gone down. When you look at the trend of diarrhea disease, it has significantly gone down, but the trend for NCDs is going up. Next page. We do know that every single second, as we're counting, can we count 1 to 5 right now? 1, 2, everyone, 3, 4, 5. What is 28 times 5? 140. My math is good. While Hambobado, we are still calculating. So in these 5 seconds, 140 lives have just passed on, and this is because of NCDs, just within these 5 seconds. And we do know that this is between the ages of 30 to 70, but out of these 28 lives, 25 of these are happening in low and middle income countries. So this is why this is a very big, significant problem for us, and this is why we really need to take immediate action. Next slide. The trends on the burden of Sub-Sahara, I will not be going very much into details, but this is just a comparative again between 1990 and 2017. Next slide. Again, this is a detail of the previous comparative, just a look at HIV. I'll just take a look at HIV and hypertension. So when we look at 2003, we had 25 million cases of HIV in the Sub-Sahara. Less than 5% had good viral control of their viral load. Less than 5%. and we had 3 million new cases each year, according to 2003. And we had 2.3 deaths each year, according to 2003. But when we look at hypertension, and we look at currently, in comparative of what is happening with HIV, 2021 HIV had gone from 25 to 26 million, which is just a 1 million difference, but over 2 decades of comparative, more than 80% in the Sub-Saharan region had well control in their viral load. We had 0.9 of new cases. We can see the significant drop, and 0.4 of premature death. But when you look at hypertension, we currently have 100 million. This is 2011, so plus. Less than 5 control of what was in HIV is actually in the hypertension, and 3 to 4 million new cases in the Sub-Sahara each year. Next slide. This is for 2016. It shows 33% of the burden of diseases from NCDs, which currently Dr. Buguyu, I think, is almost 38. That has not yet come out, but we're looking at a rising trend. Next slide. Data from STEP survey. Because of time, I'll not go into the details, but just a highlight is for alcohol drinkers, we do know that 29.3% averagely of Tanzanians use alcohol. And I just saw the post yesterday in Miladayo saying that the minister had just made one of the notice that we're the 3rd among the alcohol drinkers in Africa. Nothing to be proud of there, but just shows that the trend has shifted, as Dr. Bugu had said in some of the sessions with the media, that it was from 9 point something, but now we are at 10.4. 10.4 liters per year. That is a 10-liter bucket. And I just want to note that this is not 10.4 of beer, this is of pure alcohol. Beer is only literally 4 to 5%, so pure alcohol. So you can imagine the number of buckets when you want to get the purity. So we have a lot of tobacco users and etc. The numbers are hopefully expected to go up. Next slide. Key risk factors are very common. Everyone knows them. Smoking comes in all forms of modality right now. Now we are moving from talking about cigarette smoking, we are going towards shisha smoking, vaping. Shishas are everywhere. Every single corner of a restaurant, they have not been regulated, and etc. Alcohol, we see even on the sunrise, mornings, people are drinking from morning to morning. Overweight is on a rampant rise. Everything is tremendously giving us a prediction of the worst outcomes in the next 10, 20, 30 years to come. So these are things that we really need to look at. Next slide. So NCD epidemic reasons and attributes. These are all factors, you can name them, the interchange between aging, which is now not the major issue with us, urbanization, society transitions. Next slide. So all this, I think when you look at, you can easily relate to one or two. When you look at this, I think one can easily relate, if it's not to a burger, if it's not to a Coca-Cola, to vaping, if it's not to whatsoever risk factor, you name it. Next slide, please. Data statistics, I've spoken a lot about this, but this is just important that the WHO had given projections on every dollar you invest, you get a $7 return. And an important issue is on the expenditure. If 80% of the NCD burden is on low and middle income countries, the expected by 2030 is that 20 trillion will go into our expenditures. And we do know that the burden of NHIF, which has heavily been burdened by NCDs, is literally currently on a rise. A lot of the healthcare expenditures of government are going towards treating NCDs. Next slide. Yet only 3% of the global aid goes towards NCDs. So you can see the burden and you can see the numbers. 3% of the global aid is focusing on NCDs, and this is the actual state of where the money is at right now. Type of prevention, most of the money is going towards secondary and tertiary prevention, and literally very insignificant is going towards primary, but the best practice recommends the right-hand side. And this is the level of effort that is going in. Next slide. So what should be done? The first is on cost optimization, and I will talk a bit very lightly about this, but also all this information we're sharing here, it should be shared among key stakeholders to make very easy, meaningful engagement. Just the simplest of term of counting 1 to 5 and multiplication is a simple way of telling a policymaker that in these 5 seconds we have 140 lives lost. This is because of NCDs. Multi-stakeholder collaboration cannot be overemphasized, from the private towards the public partnerships. And so this comes from fighting pollution towards other risk factors which are modifiable. Next slide. And lessons from this partnership is, number 1, to engage the stakeholders. So about a month ago we had a workshop of trying to work on policy briefs and policy recommendation for alcohol. And when we took time to look at what the legislature says, the law says about the regulation, we were amazed. Number 1 is it speaks very clearly on who should be sold the alcohol to. Number 2, it speaks very clearly on the time limitation. If we are to follow the law, it says that no bar should be open from before 2 p.m. and on normal working days, every bar should be closed by midnight. On Friday, you need special permission. There is so much that has been written in there, but not much is being implemented for so many reasons. Because number 1, the policy is from 1978. The fine of the policy says, if you break any of the rules, you are charged with 2,000 shillings. Now, 2,000 of 1978 is a lot of money. But 2,000 of now, I think we all can sponsor 10 bars to that fine for even a week. So there's a lot that needs to be done in terms of stakeholder engagement. So when you talk about engagement, you do not limit yourself only to the policy, but you also go to the companies and you talk to them, you talk about what is actually happening. So previous slide, please. There's one thing that I always emphasize on is on zero-cost interventions. Sometimes we think that it takes a lot of money to do a lot, but sometimes it takes zero cost. A good example is standing, presenting, talking to a crowd, talking to a number of students that you find on the road when you're walking home and telling them, do you know the effect of eating too much sugar? Do you know the effect of physical inactivity? Talking to a family member who has been drinking excessively for so many years on the impacts of drinking. Talking about smoking when you go to a hotel room, you're a non-smoker and you find the room probably smelling of smoke. There is something called secondary and actually tertiary impact of smoking. We all keep quiet, but the impact is that tobacco goes on us even if we're non-smokers. So all of these are key issues that take zero cost to intervene. Finally, we need to produce enough data. So yesterday I met the country coordinator for PEPFAR and I told them why a majority of your activities for the past 2 decades have been focusing on HIV/TB. When will it be on NCDs? And the issue is that we don't have good aligned data. That is what the response was. So we do need to produce enough data, enough references to disseminate this information. And lastly is integration of integrations. This is my last comment. When we integrate, we need to also integrate because sometimes we integrate and we're still disintegrated. So thank you so much. These are my conclusions. Next slide. Just a summary of all the conclusion, which is what I said, but thank you so much for listening and looking forward to further discussions.
Thank you, Dr. George, for this very good overview on the current situation. And now we would like to take the opportunity to present you 4 best practice cases here from the country. And we would like to start with Dr. Henke, oncologist, who will present his experiences with the Marangu Hospital together with Dr. Goodluck, who is also here in the auditorium. So please, Oliver, go ahead.
Thank you very much. It's the presentation THS Can Start. Yeah, thank you, Harald, for the introduction. My name is Dr. Oliver Henke. I worked many years at KCMC, helped to establish the Cancer Care Center there. Now I'm a senior researcher and head of the Global Oncology Working Group at the University in Bonn. And I'm going to present, as this is a hospital partnership program, together with my colleague Dr. Goodluck Male from Marangu Lutheran Hospital. Next slide, please. We heard a lot about the burden of NCDs, And we heard a lot about figures, and we even heard the figures from Dr. Ubuguyu about cancer, that we have 45,000 new cases each year, and we have 26,000 deaths due to cancer. Now, these are the estimations from WHO, and they are based on, let's say, quite weak databases. So most of the publications assume that we are even having a higher burden, but it's not really documented. However, if we look at the global cancer mortality, and these are the latest figures from WHO from 2020, we had almost 10 million deaths worldwide, and 7 million out of these occurred in low and middle income countries. And if we compare this, next slide please, to the incidence, so the new cases, we see that 71% of the global mortality occurs in low and middle income countries, but only less than 60% of the new cancer cases. And if we translate that very simply, we can say you have a higher chance of dying from cancer if you are living in a low and middle income country. And why is that the case? Next slide, please. It's the so-called late stage presentation. 70 to 80% of all cancer diagnoses in Sub-Saharan Africa are diagnosed in stages 3 or 4. Stage 4, as you know, hardly to be cured. Stage 3, you have to use multimodal treatment approaches, which is very costly. We just heard the cost implications for that. And why do we have this late stage presentation? First, there are limited financial resources. It's on the patient side, but it's also on the service provider side. And then we have on the patient side a lot of trust in local healers, which leads to a later presentation because they get treated for a year, 1.5 years from local traditional healers before they come to the hospital. Thirdly, we have a quite low health or cancer literacy among the population. And then we have also limited knowledge on the healthcare worker side. And we just heard it. We had over decades, we focused on communicable diseases, malaria, HIV/AIDS, tuberculosis. By the way, those combined in 2020 had a mortality of 2.5 million compared to the 10 million of cancer cases. Now, and the last point is weak infrastructure, long distances to treatment. You have a patient from Beja, you tell him you need radiation, you have to go to Dar es Salaam. He or she will probably never turn up there. And this is why we wanted, please go one slide, one previous slide. Yeah, so our hospital partnership project should tackle these last two problems, limited knowledge and a weak infrastructure, long distances. Next. Our project called Can Start, Cancer Staging and Early Referral Treatment for Treatment, and this is now, it's a 2 years program. We are approaching the end of that program, and I would give now to Dr. Goodluck to give you some more information about this.
Thank you. Pleasure to be here. My name is Dr. Goodluck Malde. I'm a medical officer in charge for Marangu Lutheran Hospital. So a brief tour. This is Marangu Hospital is one of the faith-based under ELCT, Evangelical Lutheran Church in Tanzania, Northern Diocese. And we have a catchment of around 400,000. And our hospital has a bed capacity of 80 beds. And we have a clinical laboratory, X-ray unit, and we used to have an old ultrasound with a couple of malfunctions, but through this program, we were able to have portable digital ultrasound, which we use for our screening programs. And the goals, actually, some of these, we are working on them, and to healthcare workers was sensitization, for suspected cancer cases at Marangu Hospital. And we had some workshop training jointly with team from Marangu, KCMC Oncology Unit, and our partners from Bonn, Germany. But also, we had this goal to discuss using a Zoom meeting, Zoom platform. So we had our tumor board. This is bi-monthly, so every 2 weeks we are doing, is something that we are doing, it's ongoing. But also we are able to, stage cancer cases that we are suspecting using point of care ultrasound. Also, it has helped, has been our goal, but we were able to increase the quality of documentation for the population-based cancer registry. Yeah. Next slide. So this is, we started with basic oncology workshop course. This is in Marangu. Actually, as you see, we involved international partners as well as, next slide, as well as local from our referral hospital at KCMC. So both international and within the country experts. And this is, again, a training course which was done in KCMC. So we also involved our colleagues at KCMC who also involved in the training, as you can see on the picture. Next. Yeah, so this is a device that we are using, and please, my colleague will continue.
Thank you very much. So you see that device, one slide back please, is very important because we said let's take the Philips Lumify. There are other devices, but you can use it with just a very normal tablet or even a mobile phone. So if that gets broken, you just buy it locally, which means we are not transferring any machines that cannot be maintained, etc. Next slide please. So you see this is an example of our bi-monthly tumor board. Please start that video. And we are using video loops. Yeah, can you start that video? So we're not only looking at ultrasound pictures, we look at video loops. That gives us a better impression and a better interpretation for the experts that are taking part in this tumor board. Next slide. Just very briefly, I present you one case. No, go, yes. Here you can see on the left side the uterus and the cervix of the uterus, and you can see clearly there's a tumor, so it's one of those massive cases of cervical cancer. And next slide, the video, please try to start it. You can see on that video loop that the organ, the tumor is not invading other organs, so we can have the clear line. So that was our very first early stage diagnosis of cervical cancer, of course not confirmed by biopsy yet, but we could then discuss with the colleagues in Marangu, this is a case which is in stage 1 or 2, please refer as fast as possible to KCMC, and that happened, and this woman got treated, and she's alive, and she didn't occur later in stage 3 or 4. Next slide. We're documenting this in SATMED, which is basically an online platform module that fulfills the Tanzanian standards and the EU standards for data privacy. Next slide, you can see the colleagues from Marangu can fill these fields, and then they can even copy paste it for their own medical records, electronic medical records, and with this we can also enhance the quality of the population-based cancer registry by putting those staging information into the PBCR. So what has been achieved? We have regular online discussions every 2 weeks. The colleagues use the ultrasound machine also outside the project, so it's also an asset for the patients to get free diagnosis. We discussed 26 cases. Not all of them were suspected or suspicious cancer cases. 3 we could identify in early clinical stages, and we could enhance the quality of documentation. Thank you very much.
Yeah, thank you both for this, I think, very, very impressive talk and project and your successes. I think this is really something which can be implemented anywhere, basically, so it can be really rolled out. We can discuss that later. So the next best practice example is from emergency medicine. Dr. Frieda from the emergency medicine department from KCRI will present the development of a master course in emergency medicine. Dr. Frieda.
Good afternoon. As I was already introduced, my name is Dr. Frieda Shayo, an emergency physician at KCMC. And as we already introduced for this conference, tunataka tiba bora, sio bora tiba. So if you can't prevent it, we come to treat you. So as we know, currently our government is in a program of increasing emergency departments in all over the country in order to improve the care, because emergency area is where is the entry of the hospital. And we treat as our time is a pressure for us. So for these NSAID cases present to us, we need to treat it appropriately. So we all know emergency is a new specialist in Tanzania, and currently we have only one university in Tanzania or in East Africa who can provide emergency residence. Next. So this is just a small background of the emergency training in Africa. It started in 2003 in South Africa. Then later, 2010, Tanzania we came to introduction of a residence at Muhimbili University, where the first graduate was 2013. So as you see the map, it's just a few countries which are currently providing emergency residence for current. And so this shows the gap. That's why we want to introduce this field in Tanzania in order to improve very fast. So status for now, as we know, there are 17 working emergency departments all over the country, and 102 in construction under government sponsorship. So we have 92 critical nurses, but specialists, doctors, we are 79. But among 79, only 45 are in the field. So you see the gap. And in order to equip all the doctors in a current ongoing project of building the emergency, we at least need a 500 emergency physician in order to cover the all facilities which are now building by government. So next. So this gives us, you see the gap. We don't have emergency physician and government ongoing building the emergency. So we conducted a need assessment, a small survey, it's a Google map, to see the need of emergency physician. So the survey was conducted as projected, and next. The results, we see the need. Of course, the gap was in the knowledge part and the skills part, because the emergency is much of skills. You have to act very fast. So we have an issue of a disaster, point of care, and leadership, because for current, the residents who are graduating at Muhimbili, they are all become a leader, because they're going to become head of department. So that's also another gap. Next. Part of skills we need, because emergency now, we are dealing with the emergency care and critical care. So you see there's also a movement of building ICUs. So we still have a big gap. Toxicology, we don't have. Sport medicine, we don't have. Those are super specialty in emergency field. Next. So this came with a collaboration with DADI. We started, we are now in a progress to develop a resident program at KCMU College in Kilimanjaro. So we set a meeting where we conduct a curriculum development task force, and now you know the process of submitting stakeholders, but now we are in the TCU accreditation point. So next. We had a specialist, but part of our skills, we had a collaboration with DADI in Germany. We went to Germany to be trained in a part of skills. We went to one of the biggest skills lab in Germany, in Marburg, where we were equipped and more trained on how to train people on the skills. Also, we do some discussion on how to teaching methodology. All these were done to equip the trainers in order to be a good in provision of a case. Also, emergency is so broad. There's also part of emergency out of hospital. We went to visit the dispatching center in Marburg, and the way they're running EMS. This is also another gap. We don't have EMS, we don't have paramedics. Also, it's another gap to develop in emergency field. So in conclusion, we will be the second university in Tanzania, of course in East Africa, to have a resident in emergency medicine. And it is our call as an open eye. Of course, after being accredited, you see all the announcement. But it's an open eyes to, there's a coming resident in the KCMU College, which will be conducted 4 years at KCMC. So we want to thank you, Daddy, and Philip University in Marburg. They're the one who accommodated us when we went for simulation, and GIZ. And this was a group, we went there for capacitation as a TOT, and I want to thank you all for listening.
Yeah, thank you so much, Dr. Frieda, for presenting this work in progress, basically. So we hope that your master program can start next year with the next enrollment period, and when we are looking forward to the experiences of this course. Yeah, this moves us now to the next project, which is the bachelor course for NCDs, and Dr. Christian Kreisel from Marburg will present this piece. Do you want to?
Yeah, good afternoon. My name is Christian Kreisel. I'm from the University of Marburg. I'm a specialist in family medicine and in pre-hospital emergency medicine, and since last week also in inter-hospital emergency medicine. Emergency medicine, as Frieda said, is you have to make fast decisions and you have to act very fast. That's why I want to do a very fast presentation that we can come very soon to Irene's big project. So we did this project together with Kilimanjaro Christian Medical University College and the Philipps University of Marburg. It was a teaching project for bachelor students in the third year. It was financed by the Hospital Partnership, which is a program under the GIZ. We had many discussions now already about morbidity and the numbers and the meaning of NCDs. But unfortunately, if you look to the curriculum for bachelor students, you will find multiple blocks for infection diseases, but no additional learning block for NCD. So there's a huge gap between the reality and what we can see in the curriculum. So next slide, please. So if you also go to on the left-hand side, you can see the top 10 diseases in the emergency department in KCMC, and here on the left column, you can see the adults, and most of them are NCDs. So we have selected 10 of the diseases, and next slide. We confirmed them in online lectures. All the lectures had the same structure, a real case from KCMC, a lecture about 30 minutes, and then we went back to the case and we gave the resolution of the case. So then we recorded all the lecturers. This was one lecture I did together with Professor Maro and with Farah Yaqasa about anemia. Next slide. So all in all, it was a voluntary course for the students. 242 students take part of the project. Then we said, okay, let's do a pre-test. We gave them 50 questions about NCDs. Then we gave them the online lecturers, and then we asked them another 50 questions about NCDs. And as you can see here on the beginning, on the pre-test, most of the students, it was more difficult for them to give the correct answers about this. Okay, of course it was a bit difficult questions, but after this 10 online courses, you can see the improvement of their knowledge. Next slide. So all in all, we can say there's a huge gap between the reality we have discussed already and what is shown in the curriculum. So that's why we think it's very important that within the curriculum of KCM UCO, but maybe also national-wide, you should think about to increase NCD, the meaning of NCDs in the curriculum. And maybe we should also expand to practical skills, because we talked already about, or Dr. Frieda talked about practical skills. Maybe this can be a next thing. And I think what is very important, hospital partnership, it's a very easy to access. And for us, it was the first project. This was the way how Marburg came into Tanzania. It was the first project. It was easy to get the money, to get the funds, but I think now with Irene, we can see what can happen on the end. Thank you so much.
Yeah, thank you very much, Dr. Christian. I think this is another good example which can be rolled out also to other areas of the country very easily. Online courses, online lectures, not necessarily physical activities on site. And I know that Afri Health, for instance, is also an organization which offers lots and lots of modules in this regard. So I think we have to change also the curricula for the students at universities, slowly but consistently. Yeah, and finally, I would like to ask Professor Irene Kivelo to the stage from KCRI. She will introduce to us the Center of Excellence project.
Okay, thank you.
In laboratory medicine, I have to say.
THS. Okay, thank you. Good afternoon. My name is Irene Kiwelu. I'm a research scientist and associate professor in medical parasitology and molecular virology, working at Kilimanjaro Clinical Research Institute, which is under KSMC. So I am very happy this afternoon to present to you or to give a story. Can you go to the first slide about the ongoing or establishment of the KSMC Center of Excellence Laboratory. So as you see there, the title of my presentation is about harmonization of KSMC laboratory services and establishment of KSMC Center of Excellence Laboratory. So this is the project which is supported by German government, and we got support from Professor Harald Renzi and also Christian, who are here with us this afternoon. Next slide, please. So that is the overview of my presentation. Next slide. So this morning I attended a session on infectious and non-infectious diseases, and now we are talking about non-infectious diseases or NCDs. So we always forget, I think Professor Harald will agree with me, we always forget about laboratory, but we know laboratory is the backbone of all the diagnosis, laboratory diagnosis for patient in order the patient to get a good management. So KSMC, we have 3 laboratories. Those are the 3 institutions. We have Kilimanjaro Christian Medical Center. We have teaching institution, Kilimanjaro Christian Medical University College, and then we have Kilimanjaro Christian Medical Center. So these are the 3 institutions which are under Good Samaritan Foundation. And in these 3 institutions, we have 3 laboratories. So we have, can you go back, please? We have clinical lab, which is under KSMC. This is dealing with the patient care. They also do practical training for undergraduate students, and they do some research as well. And then we have KSMUCO, whereby they do, the main activity is practical training for students, and also they do research. And then for clinical, for the research, we have KSRI, Biotechnology Laboratory. This is specifically for research. And we also act as a backup for clinical lab in case there's a breakdown of machine or they have any problem, specifically hematology and chemistry. We also provide a training facility. This is KSRI Biotechnology. So these three laboratories, according to KSMC management, they realized that we are under one management, but we are not collaborating or working together. So because of that, can you go to the next slide? KSMC management try to do some analysis or some research to find out why is these three laboratories are not operating together or working together. So they found some challenges. One of the challenges is about duplication. Okay, so those are the challenges. Duplication, you see clinical lab, they have all those 5 units. The same applies to the research within the same institution. And then with this issue of underutilization of research lab, we have all those type of those units, and we have like 11 units, but all the units are underutilized. There is issue of heavy workload in relation to clinical lab, whereby they have heavy workload, which lead to they don't meet the turnaround time. Patients are not getting results on time. Next slide, please. And then another challenge which the KSMC management observe is about the inadequate space for routine tests and also training. So clinical lab, they have problem of space, and at the same time we have BSL-3. We know BSL-3, this is a very, very important laboratory, especially when it comes to the problem of imaging and re-imaging infectious diseases. So we have a problem with the space in relation to those two labs, clinical lab and the BSL-3. So you see that that is one of the units in the clinical lab, clinical chemistry unit. Those are the students going through rotation. You can imagine how are they going to be able to understand during training. So it's very difficult. Next slide, please. And then the same applies to microbiology unit. So all these challenges affect the quality of diagnostic services and hence poor management of patients. So another challenge we also observed, KSMC medical services are expanding. We have heard about the emergency department from Dr. Flora, and we have oncology department, which has been established recently. And also, we are expecting to establish both bone marrow transplantation unit and the cardiovascular unit. And many other new departments are also going to be established at KSMC. And I'm sure not only KSMC, even other hospitals in Tanzania. So the current existing laboratory infrastructure are found not to be able to accommodate these new medical services. Then, in order to address all those challenges, the KSMC management recommended that we need to strengthen the GSF or the KSMC laboratory services in order to improve quality of diagnostic services for patient care, training, and research. So in order to strengthen, they recommended that the 3 laboratories which I have shown you from the 3 institutions should be merged under one management. And then we need to establish a modern laboratory which is equipped with high technology. So this new lab is called KSMC Center of Excellency Laboratory. Next slide, so please. So this laboratory, as I said, is a new, the project is going on, is being established in collaboration with the 3 institutions. We have members from the Philip University, Institute of Laboratory Medicine. One of them we have him here, Professor Renz Harad, and then we have Roche team. So 3 partners are supporting the establishment of this KSMC Center of Excellence Laboratory. The objective of this lab is to address the health needs with focus on communicable and non-communicable diseases, as well as imaging and re-imaging infectious diseases. As I said, we have BSL-3, but the way it operates is not at the international standard. So this building, if it's going to be completed, the Center of Excellence, it will consist with 6 floors. The project, as I said from the beginning, is funded by the German government, and the construction is funded by the Good Samaritan Foundation and its 3 affiliated institutions, KCMC, KCRI, and the KCMUCO. This is the university. The duration of this project is 3 years. It started last year, and we expect August, we expect to complete to, July 2025. So those are the units which are going to be established at the KCMC Center of Excellence, and we have administration. The lab we expect to be accredited, and it will operate based on 2 quality management system based on ISO 15189 and GCLP standard. Next slide, please. So why are we establishing this? As I said, to address the needs in terms of communicable and communicable diseases. State-of-art KCMC Center of Excellence will be established and will support diagnostic services for patient, research, and teaching services. The modern laboratory, our laboratory is going to be equipped with a wide range of lab tests will be installed in the KCMC Center of Excellence. We know some of the doctors, there's some tests which are referred outside the country. We have Lancet, which they take samples to South Africa, to Nairobi, other parts of the world, in order to be tested there. So we hope this lab will help to establish those tests within the KCMC Center of Excellence. Then, due to modern laboratory equipment, the turnaround time of lab tests will be reduced and the patient will get their results on time. Because if you are asked to send samples to South Africa, it may take maybe 14 days. So if the test will be done at KCMC, then it's easier to get the results on time. And then there is another issue, new tests such as specialized tests. This is very, very important. We know there are new tests which are not done routinely. So we need to establish those tests. And if possible, we are going to ask even the other hospitals in Tanzania to tell us what kind of lab tests are not done in their laboratory. For example, Muhimbili, Dodoma, Mbeya, Bugando. So that if we have that capacity, we can establish them at KCMC. So the laboratory will also provide the training facilities, facility for scientists, and then we will have capacity building. We'll train our lab staff, phlebotomists, biomedical engineer. Biomedical engineering is an area which is a challenge to our hospital. I think even other parts of other hospitals in Tanzania, we don't have many biomedical engineers. So that is an area who are going to service our equipment. We always outsource from our centers. The lab will not only serve the Kilimanjaro region if it's going to be established, but it will also serve the whole country, including the neighboring countries, and also will open avenue for employment. So this is the future. We'll have the KCMC Center of Excellence, providing diagnostic service for patient care, research, and training. We'll continue to collaborate with our external collaborators. As you see, center will be providing service. If you have a research-based, lab-based research, then you will get service from the Center of Excellence. The same applies to our internal collaborator. We won't forget the neighboring hospital, other hospitals, universities. So they will get service from our Center of Excellence. And that is my last slide for acknowledgement. And I would like to thank the GIZ for supporting us to come to this meeting. And I won't forget the Professor Harald for his support. Thank you. And thank you for your attention.
Yes, and thank you for your excellent presentation. So this rounds now up really here our session about 4 specific projects of collaboration. I mean, this session is about non-communicable disease, number 1. This session is about international collaborations, and I can only encourage everybody here in the room to enter these international collaborations, not necessarily with Germany, but also maybe with Germany. So there are lots of programs internationally available to to take advantage of, and international collaborations help advancement in teaching, in capacity building, in infrastructure, and also in patient care at the very end. Because at the very, very end, why are we doing all of this? We do it for our patients. We do it for our population. This is something we always should keep in mind as a physician. Yeah, we still have a few minutes for questions, for discussion. So please, if someone has a question, identify yourself, and please, short questions and short answers.
Thank you very much. My name is Sebastian from Afiacol. Afiacol is a telemedicine foundation company. We are currently in collaboration with Vodacom, and we intend to collaborate with other telecommunications nationwide. So my big suggestion is from the team. I think on the roadmap, it's quite beautiful. And unfortunately, I think the digital world is changing.
Yes.
And the population in Tanzania, we know the current economic situation and the most number of people that work. So I think when you plan and schedule, I think something of telemedicine is one of the key foundation for you to reach the magnitude. So including like emergency services, as you were saying, we have doctors, they've not been trained, education systems, we can be able to integrate the whole thing together. Digital, you were talking about laboratory, so it's one common platform where doctors and patients and real-time and emergency EMCs can all be integrated. Then data collection, government, all these kind of things. So I think when you're planning, one of the key gaps you can use to capture is the angle of telemedicine and the telecommunications companies' network access. Thank you. That's my input for
yeah, thank you. Thank you so much. I think you touched a very, very important topic, very important point. And this is also something which applies, I mean, to all of these projects. In cancer, we have heard about the importance of telemedicine, emergency medicine, teaching facilities, electronic database for patient records, and so on. So the next question is over there, please.
Thank you. Thank you for the nice presentations. My question is directed to the doctor there in the glasses. I can't remember the name, unfortunately. But when you were presenting, so when you were presenting, you mentioned something about the abuse of alcohol for the youngsters, and you also mentioned something about the rules around, closure of, these recreational places and everything. But my question is, aren't we addressing the problem at a later stage? Shouldn't the problem be addressed maybe at a younger stage? Because what I'm noticing is that, for example, most of the new schools that come up don't even have grounds for playing, like sports. We're not giving youngsters alternatives for expending their energy. They don't have a variety of outlets. So it becomes alcohol and hanging out and being cool, like, the picture you had there, becomes pretty much the only option. So shouldn't that problem be addressed from that stage to allow youngsters to have a variety of outlets, because they're really more energetic than, adults? Thank you.
Thank you very much. I think that's a very, very wonderful question. So WHO recommends something called a life course approach, whereby interventions target all levels of ages. And I think one very important thing is what you just mentioned, but that was one example about alcohol. There are so many modifiable risk factors. A lot of interventions are being done. Just recently there were in action of the cancer work with associated with a number of initiatives that are currently being done by the ministry, and luckily we have the assistant director here for NCDs, so probably can speak more. But when it comes to the intervention about alcohol, the Alcohol Intoxication Act is from 1968, which was amended in 1978. But still, right now, if a 16-year-old is found buying or drinking alcohol, it is not illegal, because the cutoff is 15 years. So there are still some gaps which are very important, but a life course approach is the right way forward, as you just mentioned.
Thank you.
Greetings. I'm Gimbo and I'm an emergency specialist and faculty from Mwimbili. I necessarily have a very good interest when it comes to NCD, and one of the most interesting presentations that I saw right now is including NCDs in the curriculum. So I necessarily didn't present, and it's very fine, but just for like a reference or an addition, I think if we're having a curriculum of NCD, and being a medical student, I know that we do learn about diabetes and hypertensive. It will not be new, but I hope there is a component of management when it comes to this in terms of their presentation, and also a component of multi-morbidity, which right now when we talk about NCD, most people will not just come with hypertension. They'll come with hypertension and diabetes, or they'll come with hypertension and HIV for that matter. So if you are creating a curriculum that we are going to advise Dr. Obuguyu here, who is our NCD desk in the country, and Mwimbili and KCMC and anybody who is having a teaching program that way, I hope when we are looking at what is in there, we're going to consider this very increase when it comes to multi-morbidity presentation and management, because I believe any healthcare is already learning about what diabetes, hypertension, cancer, etc., is. So that's, otherwise it was a very good didactic from all of you there.
Yeah. Thank you for this comment. We have unfortunately 1 more minute only left, so we have 2 more questions here.
All right. Thank you so much. Thank you for nice presentations. It was a good highlight on non-communicable diseases, but I think this is both a recommendation and a question. I think mental health is not given that much of a priority when it comes to non-communicable diseases, because it's also something that I expected to hear from this forum, but it's okay that it's not stated, and I think we have a gap in data concerning mental health issues and challenges in our country as far as non-communicable diseases is concerned. But again, we don't have data. Again, it's not a much focused research area. I think we should look on that aspect, because non-communicable diseases is mostly spoken on older people, but when we come to mental health, it affects from children. We hear suicide cases from adolescents, teenagers, and they are affecting the general future of our country. We are losing energetic young people in all these aspects without excluding the older ages. Yes, thank you.
Yeah, thank you very much. I think your point is well taken. I mean, mental diseases are part of the NCD pandemic, and one needs to conduct more research and more work on this. Absolutely, for all ages. Thank you. And one final question over here, maybe the gentleman.
Yeah, thank you. I need congratulate the presenters for a nice presentation, but my question goes to Marangu presentation. The screening is actually done for the clients coming to the hospital. Can you extend this to the community so that we can catch the cancers before they come to hospital at stage 3 or 4? Then the next question is goes to the one who presented on EMD. We have like 79 EMD specialists, but only 45, if I can remember well, are working. So what is the way forward in recommendation to the police so that we can retain as many as we train them? Thank you.
Yeah, thank you for a nice question. Actually, to respond to that, we have started during the period of pandemic, where the staff from the hospital went out to the community to give health education and also vaccination to the population. So also that we adopt during the program, we had Afya Imara program, where we go, especially our community there is mainly a church. We have a lot of churches, so we used it as a tool to reach the community. So health education, and also we can do like BMI and taking blood pressure and blood sugar, and we have reached in a period of like less than 6 months, we have reached to more than 600 people. So As well, we want to take it into another phase as we go out, also to include cancer cases as well. Thank you.
Yeah. Okay, thank you very much. Unfortunately, the time is really over, and we have to close this session, but I think the speakers are still around, so you can ask questions and get engaged. I would like to thank the panel for all the presentations and the hard work into these projects particularly, not only into the presentations, but for the projects. And I would like to thank you for your patience and endurance here during this session, and for the wonderful discussion. And it shows that the topic of NZD should get more room in this conference in the future. Yeah. So thank you very much. And we should stay here for a group picture. Yeah. What?
One update that we gather for the group picture, because there was a concern on mental health. So I just want to address the question on mental health as we gather for the picture. This year, the national survey for non-communicable diseases, I think the main issue was the paucity of data, and for the country, the ministry to plan, they need to have data, and that data is what informs the priorities. So this time, the survey included mental health modules, injuries, oral health, so all that is integrated, and we hope that we'll get a lot more data, and we'll also be able to triangulate mental health with other NCD conditions. So I just wanted to give that update and make sure that I say something in this forum.
Okay, thank you for your attendance, and the time being we are heading to Kilimanjaro for lunch and break. So we'll be back here at 2:30 for CDC Health Forum. You're welcome much. Skills.
Hizo tags. Nataka niweke tags.